Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with pulmonary medicine? Find out more right now. My guest this evening is Dr. Stephen Kariya, a well-known pulmonologist, a specialist in lung disease, practicing here right in Montgomery County. Steve, welcome to Housecall.
Thank you, David.
So tell our viewers briefly about your professional background.
Well, when I first arrived here, I thought my partners, who are now retired, some of them deceased, had hired me because I had a decent background. I was a graduate of Harvard College, Cornell Medical School, and then went to Hopkins for my residency in internal medicine, and then back up to Harvard for my pulmonary fellowship. I did some research there at the School of Public Health. After I had been made a partner here for a couple of years, they told me, you know, Steve, the real reason that we liked you a lot is because as soon as we met you, we knew that we had our Shavaskoy. For those of you who are not, it's not a Hebrew term, it is a Yiddish term, if I believe.
That's correct.
That's correct. It means someone who can work the Jewish high holidays.
That's right.
And all of my partners were Jewish at the time.
Yeah.
So,
well,
yes, I thought you might.
I appreciate that. And it sounds like you brought many tangible assets to the practice.
Well, at the time, it was mostly hard work that I brought.
Sure. So tell us something about your background that your patients don't know.
Well, I think I got into Harvard off the waiting list because I was a judo instructor for the for the 4 years that I was there.
How interesting.
And in fact, when I was an undergraduate, I also helped to not only do some judo, but also start a women's self-defense program at Wellesley College. It was called Model Muggings. So that was kind of a claim to fame that I had at that time. My roommates at the time never understood why I would come home a little bit bruised and complain about having to mug a number of co-eds at Wellesley College, but it was where a friend of mine was teaching the class, and so he got me into donning a series of garbs. We had hockey shin guards, cup for the groin, plus extra padding there, a bulletproof vest, a padded helmet on both the inside and the outside, and we would, after teaching the students a couple of simple kicks and punches, we would pretend to mug them so that they knew how to defend themselves.
Very nice, very nice.
That was a while ago, though.
Yeah, you still doing it?
Not as much, although I think my grandchildren think that I am still capable of defending myself. Sadly, I'm not.
So before we get to the topic at hand, briefly define for our viewers, what exactly is pulmonary medicine?
Well, pulmonary medicine is medicine around the patient who has lung disease. Now, I'm reminded of the sage advice from Sir William Osler that says, the good doctor will take care of the disease that the patient has, and the great doctor will take care of the patient who has the disease. So although we tend to specialize in people who have lung diseases, I'd like to try and take care of a little bit more of the patient than simply the lungs.
Sure. So one of the topics we'll be covering tonight, which I know is of great interest to our viewers, is lung cancer. What is new with that topic?
Well, I think the big thing for my practice is the understanding and the utility of CT scans. So there's a number of different kinds of scans that are used these days. But I think the CT scan for me is a wonderful window into people's lungs, their anatomy, and to find different diseases that they may have, both of the lungs and of associated other organs.
And why is it important for current and former smokers to consider getting a CT scan?
Well, smokers are, of course, at risk for lung cancer and other lung diseases that we can see on the CT scan. But we should not forget that most smokers do not die of lung cancer, but they also have many problems with heart disease. And the CT scan is also a great tool for finding a heart disease, sometimes very early on and before they have any symptoms.
So if these patients don't have symptoms and it's done for screening to protect them, is it covered by health insurance?
It is, mostly. Now, I say that because I also volunteer at a charity clinic where they don't have access to much in the way of health insurance or coverage. But for most people who have health insurance, there's a couple of criteria that you have to have for coverage for lung cancer screening. One is that you have to be between the age of approximately 50 to 80. The old criteria was that you had to have 30 years pack year smoking. So what that is a calculation of how much cigarettes you've had. 1 pack year is equivalent to smoking 1 pack a day for 1 year. 30 packs a day is, or 30 pack years rather, is equivalent to smoking 1 pack a day for 30 years or 2 packs a day for 15 years. You can do the math.
Sure.
These days, many of the insurers are following criteria that are now being covered by many health authorities, so that 20 pack years is qualifying for a low-dose CT of the chest. In addition, you have to have been smoking currently or have stopped smoking within 15 years. And this covers patients between the ages of 15 and now 80 years old.
So if somebody goes 15 years or longer and they're free of any pathology, does that mean the risk is now back at baseline?
It is close to baseline. Now, sometimes I still am looking for other diseases, so I don't always utilize a low-dose CT of the chest, but I still find those criteria to be very important for people, and it takes a fair amount of courage sometimes for people who have been smoking to own up to the fact that they had done that and that they need to be looking for problems that could have developed from this habit that they had. So I credit my patients who are often somewhat courageous, sometimes nagged by their family members, into getting a CT of the chest done.
So what kind of problems besides lung cancer can you pick up with a CT scan?
Well, a lot. First of all, there are a number of different CT scans that can be done. The one that I alluded to with the different criteria was something called a low-dose CT of the chest. And that covers from the neck down to the abdomen. And that's a little different from some of the other CTs of the chest that can sometimes be done. Another popular screening CT of the thorax, if you will, is a CT of the heart. And that's looking specifically for coronary artery disease. And so that just covers from about here to about here. So it covers the heart quite well. It misses the top quarter or so of the lungs and about the bottom 5 or 10% of the lung bases. But it still provides a lot of information, and 2/3 of the lungs is often enough to uncover some problems of the lungs. So I get a lot of patients who are referred because of abnormalities seen on the CT of the heart.
Sure. So how much radiation exposure do patients get with the CT scan? And do you have any concerns about cumulative toxicity if they do that year after year?
There is some concern about toxicity. So we can talk about millisieverts, which is the technical term for the amount of radiation exposure. But I generally try and put it at a basis that patients can understand. So we get some ambient radiation exposure just from being on the planet Earth. And so when I look at the amount of exposure that we get from doing a chest x-ray, for example, it's about 3 days. So it's almost nothing. A pair of x-rays, which is what we do with a PA and lateral chest x-ray, the standard 2-view, is equivalent to about a week. That also translates to about the amount of radiation that you get from flying cross country. So it's not very much. A low-dose CT of the chest is equivalent to about 6 months of ambient radiation exposure. A CT of the heart is about 1 year. And a regular CT of the chest, which is better resolution, but at the cost of more X-ray exposure, is about 2 years. Now, just to contrast that, a CT of the abdomen is about 3 years of X-ray exposure. So we do worry about the cumulative X-ray exposure, especially for women, because most women are at risk for breast cancer. And so we do try and limit the exposure of women to extra X-ray exposure from mammograms or CTs of the chest. But as I said, there's a wealth of information about the insides of their body that we can uncover with one of these variety of different CT scans.
We have a couple minutes before the break. Very briefly tell our viewers, besides the important role of CT scan to screen for lung cancer, is there anything new in terms of understanding etiology of lung cancer besides smoking?
There's a lot going on at the basic biologic level. How much of that is going to be skewed by current funding changes is unclear. We do know that the risks of lung cancer go up with smoking. That's pretty well established. A lot of people ask me about passive smoking. The risk of passive smoking is probably to increase the risk of lung cancer, but it's very hard to quantify passive smoking. So it's different. I mean, did your father or mother who smoked, did they smoke in your face? Did they go outside and smoke? Mm-hmm. You know, was it in the same room? Did they never do it outside? So ambient or passive smoking exposure is probably very important from a public health standpoint, but very, very difficult to measure just because we can't quantify it. We do know from other studies done usually on other people that radon gas is a risk factor for lung cancer, and radon gas is pretty prominent here in Montgomery County, I'm sorry to say. We also know that because uranium miners have an increased risk of lung cancer. I don't have a lot of uranium miners in my practice, though.
Yeah. So you mentioned radon. As you know, when people buy homes, they get radon testing. And if the radon test is a failure, does that mean that the prior owners should come to see you and get the CT scan, or is it not necessary?
We don't know the answer to that. So I do encourage people to get radon testing, you know, as a part of their purchase of a house. And we should not mean that if you do have a lot of radon gas in the house, that the house is condemned. You can usually find ways to abate the radon gas. It's usually just a matter of increasing the ventilation, mm-hmm. often in the basement and other places. So it can be done. It's hard to quantify the effects of radon exposure as it is to quantify how many cigarettes or how many pack years somebody smoked.
So it's not recommended by the American Lung Association to do a diagnostic screening every year or something?
It is not.
Okay, all right. We're going to pause briefly for a public service announcement. More with my guest, Dr. Stephen Kariya, and we are discussing pulmonary medicine. We'll be right back.
All right, look at you taking the stairs. Who are you?
We're your lungs. We are proud of you for quitting smoking, but you still may be at risk for lung cancer.
A routine cancer scan can detect it early when it's more curable. Good to know. Well, I gotta go somewhere.
So do we.
Listen to your lungs. Get a routine screening that could save your life. Talk to your doctor and learn more at savedbythescan.org.
We're back. My guest this evening is Dr. Stephen Kariya, a noted specialist in pulmonary medicine. Steve, let's shift gears now from lung cancer to another important practical topic, and that is asthma. What are some of the new developments in asthma management and therapy?
So I think it should start with a definition of what is asthma. Asthma is defined as reversible airflow obstruction. So the incidence of asthma, or how many people have asthma, changes as we get older. It starts in childhood often, and the prevalence of childhood asthma is, depending on the population series that you read, 1 in 12, 1 in 10 children will have asthma. Many of them will grow out of asthma in adulthood, and then some of them may develop asthma later as an adult. We know that there are many factors that affect asthma at various stages in life. It turns out that early on as an infant, it's the prevalence of mothers smoking that increases the risk. Having RSV infection as an infant also increases your risk of asthma. And I found it very interesting that if you have a dog in the house, that actually decreases the risk of asthma that you may have in childhood. In adulthood, the risk of asthma is related to other factors like exposure to ambient air pollution, your risk of allergies, and of course, later on in life, if you smoke.
We know that in developing countries, there appears to be an increasing incidence of so-called allergic and autoimmune conditions.
There is.
And have you noticed that same trend with asthma?
Internationally, there is. We're blessed in Montgomery County with being having a lot of international travelers. And one of the interesting things for me is, I'd read about it, but if you're a woman in a developing country, you do most of the cooking over an open air fire. And the risk of smoking-related lung diseases goes up quite a bit, not because you smoke cigarettes, but because you were cooking over a wood fire most of your life. So there's a fairly high prevalence of chronic bronchitis and asthma problems. And I don't mean to be sexist, but for many of these societies, it's more of a girls' and women's job than it is the men's job, who are usually out in the fields.
Sure. So what are the classifications? What are the different types of asthma?
There's many different classifications of asthma. Some people talk about allergic asthma versus non-allergic asthma. For most of us, we tend to define asthma because of ICD-10 coding.
Explain to our viewers what exactly that is.
So this is the International Classification of Diseases. And for us doctors to get reimbursed for diagnosing people, we not only have to categorize them or diagnose them as asthma, but we, within asthma, at least as an asthma specialist, I have to say, do they have mild, moderate, or persistent asthma? And within mild asthma, do they have intermittent or persistent asthma? And then, of course, I have to talk about whether they have asthma without exacerbations or with exacerbations, which means that they have a cold or something like that triggers an asthma problem.
Sure. And what is the stepwise classification of asthma?
Well, some people just have asthma when they get a cold. And so for those people, it doesn't make a lot of sense for them to take daily inhalers all the time. Whereas if you have severe asthma, you have problems pretty much all the time. And if you don't take your inhalers properly, you could have an acute exacerbation that can leave you wheezing and very breathless. So the stepwise classification for asthma basically follows if you only have mild intermittent asthma, you take an albuterol inhaler, taken properly when you need it. And if you're having more persistent problems, then you cascade up, often starting with inhaled corticosteroid therapy or steroid therapy that you inhale once or twice a day, depending on the medication that's required. Sometimes it gets coupled with a long-acting beta agonist, which is a bronchodilator therapy, and then sometimes adding on a different kind of bronchodilator therapy called a long-acting muscarinic agent that becomes part of an escalating asthma therapy.
One very practical question I want to ask you then for our viewers is, what is the proper inhaler technique?
So it kind of depends. There's basically two different modes of inhaler therapy. One is a propellant-driven, which doctors like me call a meter dose inhaler. And so that when you have a canister, you puff it and out sprays a canister or a spray of inhaler. And the proper way to do this is to exhale first, puff. Hold it in your lungs. Hold it in your lungs for a count of 10 and then slowly release. Depending on whether or not there's a corticosteroid therapy part of this, you then rinse out your mouth or gargle afterward. But that's a proper meter dose inhaler or propellant-driven inhaler technique. The alternative is a dry powder. Dry powders are very prominent or common these days. You usually pull down something to activate it to get it ready. You then put it in your mouth and then you can dispense with the inhaler. Studies have suggested that 75% of people don't know how to do it. Studies also suggest that between 40 and 60% of nurses don't know how to do it. And probably fewer than that doctors know how to do an inhaler properly. The only classification of healthcare workers who know how to do this right are respiratory therapists.
Interesting. You mentioned the powdered inhalers. I'm sure pharmacologically they can provide benefit, but does the powdered medium render the patient more vulnerable to coughing? Does it irritate the airways?
It can irritate the airways. The inhalers, well, first of all, you have to understand a little bit of particulate matter deposition. So I hope I don't go off on my nerdy background, but I did a little bit of research as a pulmonary fellow back up at the Harvard School of Public Health on this. And so you want to get the particle size very small. And the ideal size is 2 microns in diameter, which is about a third of the diameter of a human hair. It turns out to be almost exactly the right diameter for the tuberculosis bacilli, which causes tuberculosis, of course. And I think that's because nature designed the tuberculosis bacilli to be one of the most efficient respiratory-driven particles that is a model for many of the other things. So that's what they try and design a lot of particulate matter. The powders are kind of irritating for some people. So you have to make sure that it's a dry powder. The dry powders usually have to be stored in a dry environment, not in your bathroom, but usually someplace less humid than the bathroom is. And you have to get rid of them often within about 30 or 60 days because moisture is the enemy of particle deposition. So once the moisture gets in, the particles tend to clump, and then it becomes much more irritating. Most of the particles will deposit in the back of the throat. Only a small fraction will get all the way down into the lungs.
Interesting.
By the way, one of the other things that some people may be interested in, what is the environmental impact? So it turns out that the propellants provide some CO2 emissions problems. So in a side job, I also am a contributing editor for the New England Journal of Medicine, and one of the more interesting articles was about the public health consequences. A metered-dose inhaler, the propellant gas, has about the same environmental damage as driving a standard family sedan, gasoline of course, not electric, about 50 miles.
Wow.
And in contrast, the powdered inhalers, it's only about 2 miles. So there is some environmental impact. The powders are often cheaper to manufacture, so that's why they're very popular. And medically they are equivalent, but there are a lot of my patients who have difficulty with the cough reflex that you talked about with the powders, that they just don't have as much with the propellant-driven or metered-dose inhalers.
Sure. So you have to really individualize.
Well, you do.
Yeah. So if our viewers have any questions, Steve, how can they reach you?
Well, they can reach me through my office. My office number is 301-942-2977. They can write. I think we'll also be trying to put up one of my several email addresses if people have some individual questions.
Great. Well, thank you for a very informative interview.
Thank you, David. It's great to see you.
Great to see you, my friend. My thanks to Dr. Stephen Kariya for an excellent interview on pulmonary medicine. My thanks to my team here at the studio for making this show happen. And most important, my thanks to you, the viewer, for welcoming us into your home. Let us know how you're doing. You can reach me on the website listed at the bottom of the screen if you have any suggestions for future programs. As for our next show, it's going to be a very important topic. We will have a rheumatologist practicing here in Montgomery County giving an update in gout, a very common rheumatologic condition. It's going to be an important show. See you then next time for another edition of Housecall. Good evening.